Hello and welcome to ER Mentorship Hub, the go-to channel for emergency room professionals and enthusiasts. Today, we're diving into the critical world of intercostal or chest tube insertion. We'll explore indications, contraindications, complications, and most importantly, how to insert one. Whether you're a seasoned ER professional, this video is packed with essential information. Please watch our videos on pneumothorax, both simple and tension type, the recognition of pneumothorax on ultrasound, and needle thoracostomy, linked in the description below. Not just a medical term, but an urgent condition where air invades the pleural space, causing the lung to collapse. It comes in two main forms, a regular pneumothorax and the more dangerous tension pneumothorax, where the air trapped in the pleural space creates a one-way valve effect, leading to potentially life-threatening situations. Diagnosis is clinical. Watch out for the telltale sign of absent breath sounds on the affected side. Remember, especially in cases of tension pneumothorax, time is of the essence, and clinical diagnosis supersedes waiting for radiographic confirmation. Let's delve into when you should. The indications for managing pneumothorax range from suspected tension pneumothorax and penetrating chest injuries to more specific conditions like hemopneumothorax and spontaneous or iatrogenic pneumothorax. Understanding these indications helps in timely and appropriate intervention, which can be life-saving. However, not all cases are straightforward. There are absolute contraindications, like emergent thoracotomy, and relative contraindications, including coagulopathy and pulmonary adhesions. Each contraindication requires careful consideration to avoid exacerbating the patient's condition. Now let's talk tools. The tube thoracostomy tray and the right chest tube size are crucial. For instance, an adult male typically requires a 28 to 36 French tube, while a neonate needs a 10 to 12 French tube. Also, medications like lidocaine for anesthesia are essential. Procedure is not just a matter of protocol, but of patient safety and procedure efficacy. The procedure of tube thoracostomy. Let's walk through the procedure step by step. 1. Elevate the head of the bed 30 to 60 degrees if possible. This lowers the PM, thus reducing the risk of iatrogenic injury. 2. Sterile skin preparation with a sterile drape. 3. Anesthetize the appropriate area subcutaneously up to and including the rib periosteum with 5 milliliters of 1 to 2% lidocaine with epinephrine. 4. Using a number 10 blade, make an approximately 2 centimeter skin incision over the desired intercostal level of entry, most often the 4th or 5th intercostal space in the midaxillary line. If the incision is placed below the 5th intercostal space, the risk of subdiaphragmatic placement into the abdomen increased. 5. Bluntly dissect with a hemostat or Kelly clamps through the subcutaneous tissue to the level of the intercostal muscle with the intermittent opening of the dissection instrument during advancement. 6. Digitally palpate the selected intercostal superior margin of the inferior rib. Pay careful attention to avoid the neurovascular bundle lying inferiorly. Move your finger around to confirm correct you are in the pleural space by feeling the lung. 7. Guiding the closed Kelly clamp over the upper margin of the rib, enter the chest wall. This will require some controlled force and a twisting motion. Once the pleural space is entered, a rush of air or fluid should occur. Uncontrolled force and a lunging motion can result in penetration to the lung, heart, liver, or spleen. 8. Open the Kelly clamp while still in, and then withdraw while the clamp is still open to enlarge the dissected tract of entry and allow easier passage of the thoracostomy tube. 9. Explore the dissected tract with a sterile finger to appreciate lung tissue and possible adhesions. 10. To tube needed, measure the distance between the skin incision and the apex of the lung. If preferred, place a clamp over the tube at the estimated length. 11. Grasp the proximal end of the tube with the large Kelly clamp and pass the tube through the thoracic cavity along the previously dissected tract. 12. Teleclamp and continue to advance the tube posteriorly and superiorly. Make sure all the fenestrated holes of the tube are within the thoracic cavity to prevent unnecessary manipulation or replacement of the tube. 13. Once the tube is in the desired position, tube to the drainage device. Once connected, release the cross clamp on the distal end of the tube. 14. Secure the tube to the skin with 0 or 1/0 silk or nylon suture. I would suggest speaking to your senior in the emergency or surgical departments, as each has their own preferences on how they want the tube secured. 15. Apply petroleum gauze over the skin closure surrounding the tube, and then apply a support dressing with 4x4 gauze and adhesive tape. Even with the best technique, complications can arise, empyema, or even tube dislodgement. Being aware of these potential issues allows for rapid recognition and management, minimizing harm to the patient. And finally, some pearls of wisdom. For instance, the water seal in the chest drainage system acts as a one-way valve. Bubbling indicates an air leak. And with the tube, timing and technique are crucial to prevent complications. These tips can make a significant difference in your practice. We hope this walkthrough of pneumothorax and tube thoracostomy has been enlightening. Remember, in the ER, knowledge and skill are your greatest tools. If you found this video helpful, please like, share, and subscribe to ER Mentorship Hub for more insights. Stay tuned for our next video, where we'll explore another essential ER procedure. Until then, keep learning and stay